Welcome to Cardiology 305. Today we're diving into atrial fibrillation, the most common sustained arrhythmia we see in clinical practice. I'm Dr. Fernandez from Miami, and in the next few minutes we are going to cover everything from that atrial fibrillation really is, to the brand new staging system, how to diagnose it, and the latest breakthrough in management and prevention. Whether you're a patient, a medical student, or just someone who wants to protect your heart, stick with me. This could save a life. Let's get into it. Here's what we're covering today: definitions and ECG hallmarks, the new classification and staging system, global and US epidemiological pathophysiology, diagnosis from smartwatches to the gold standard, rate versus early rhythm control, stroke prevention, risk factor modification, ablation, breakthroughs, and finally, complications plus your clear action plan. From silent fibrillations to powerful prevention, let's keep hearts in rhythm. What exactly is atrial fibrillation? Atrial fibrillation or atrial fibrillation, AFib, is a supraventricular tachyarrhythmia where the atria activate in a completely uncoordinated way, losing their effective contraction. On the ECG, you see three key hallmarks: irregular R-to-R intervals, no distinct P waves, and instead of fibrillatory or F waves. For diagnosis, we generally require at least 1 minute of this rhythm. Think of it like a chaotic drum solo in the atria, fast, irregular, and totally out of sync with the rest of the heart. This is straight from the 2023 ACC AHA guideline. How we classify AF temporal? We used to use terms like chronic AF or long AF. Those are now obsolete. Here's the current classification. Paroxysmal atrial fibrillation terminates spontaneously or with intervention within 7 days. Persistent AF lasts longer than 7 days and usually needs intervention to stop. Long-lasting, persistent means is being continuous for over 12 months. And permanent AF is when the patient and doctor jointly decide to stop trying rhythm control. We also now recognize subclinical AF detected by devices and atrial high rate episodes. Note that only specific valvular cases like rheumatic mitral stenosis or mechanical valves still requires warfarin. AF as a progressive disease, AFib, is no longer seen as just an on-off switch. It's a progressive disease with a new four-stage staging system. Stage 1, at risk. You have risk factors like hypertension, obesity, or diabetes, but no atrial fibrillation yet. Stage 2, pre-atrial fibrillation. There is already atrial pathology. Stage 3, atrial fibrillation is present. This includes paroxysmal, persistent, or even post-ablation AF. Stage 4, permanent. End stage, where rhythm control has been abandoned. The key message: AF is a continuum. An early intervention can completely change the trajectory of the disease. AF worldwide, a growing challenge. Globally, 59 million people are living with atrial fibrillation, with over 5 million new cases every year. In the US, prevalence is projected to jump from 5.2 million in 2010 to 12.1 million by 2030. Lifetime risk is 30 to 40% in the wide population. Alarmingly, we are seeing a rapid rise in younger adults aged 30 to 44, largely driven by obesity, hypertension, and diabetes. In Miami and across the country, AFib is hitting younger hearts harder than ever, which means lifestyle really matters. What fuels atrial fibrillation? Leading risk factors. Let's talk risk factors. The big modifiable ones are high blood pressure, elevated BMI, tobacco use, excess alcohol, and sleep apnea. Non-modifiable factors include older age. Risk increases 1.66 times every 5 years. Male, sex, diabetes, heart failure, and genetic predisposition. The good news: the structural lifestyle changes can reduce AF burden by up to 39%. That's a powerful number. Why AF begets AF? The vicious cycle. Here's why atrial fibrillation begets AF. It's a vicious cycle, triggered like pulmonary vein atopy, autonomic changes, or inflammation start it. Then electrical remodeling shortens the refractory period, causes calcium mishandling, and slows conduction. Structural remodeling brings atrial fibrosis, more inflammation, and oxidative stress. The result? AF promotes remodeling, which promotes even more AF. Breaking this cycle early is critical. Diagnosis, atrial fibrillation, tool and confirmation. Diagnosis start with the gold standard, a 12-lead ECG confirmed by a clinician. For monitoring, we use Holter monitors for days, even monitors for weeks, patch monitor up to 14 days, or implantable devices for continuous tracking. Especially good for subclinical AF. Smartwatches can flag possible AF, but they have about 33% a false positive rate, so always confirm with your cardiologist. The USPSTF currently says there is insufficient evidence for routine screening in asymptomatic people over 50, as shown in the Apple Heart study. Management, rate versus early rhythm control. For management, we have two main strategies. Rate control uses beta blockers, non-dihydropyridine calcium channel blockers, or the digoxin. A linear rate target is often fine, but avoid non-DHP calcium channel blockers in heart failure with reduced ejection fraction. On the other side is early rhythm control with antiarrhythmic like class 1C drugs, if no structural heart disease, amiodarone or dofetilide. The AFNet4 trial showed that starting rhythm control within the first 12 months of AF reduces cardiovascular death, heart failure, and stroke. Guidelines have shifted strongly toward early rhythm control, ablation, PVI, and pulse field revolution. Pulmonary vein isolation or PVI remains superior to drugs for symptomatic paroxysmal atrial fibrillation and is preferred in heart failure patients. But the real breakthrough is pulse field ablation, PFA. It's a non-thermal and tissue selective, making it gentler than traditional radiofrequent ablation. The ADVENT trial showed 73 success rate, non-inferior to radiofrequency, with a superior safety profile and shorter procedure time. Recurrence can still happen in about 40% of cases, but repeat ablations work well. Think PFA as a precise electrical reset for the heart. Stroke prevention, SHAT2, BASC, and anticoagulation. Stroke prevention is critical. AF increases stroke risk fivefold. We use the CHATS-BASC score. Anticoagulation is recommended at greater or equal to 2 in men, greater or equal to 3 in women. Direct oral anticoagulation or DOACs are preferred, with apixaban often having the lowest GI bleeding risk. Warfarin is still used for mechanical valves or rheumatic mitral stenosis. Aspirin alone is no longer recommended for patients who can take oral anticoagulant. Left atrial appendage occlusion devices like Watchman or Amulet are non-inferior or even superior in some cases, but studies are underway. Never let AF steal a beat or a brain. Risk factors modification, the game changer. Risk factor modification is now a class 1 recommendation. A structure lifestyle intervention can dramatically reduce AF burden. Key targets at least 10% weight loss. The legacy trial showed 63% reduction in AF burden. Regular exercise 30 minutes most days as in CardioFit study. Reduce alcohol to less than 1 drink per day or eliminate it. Treat sleep apnea with CPAP. Keep blood pressure under 130/80. In special populations, pregnancy, elderly, athletes, obesity, or CKD, we tailor the approach. This is truly a game changer. Complications, emergent therapies, and your action plan. AFib carries a serious risk, 2.4 times higher stroke risk, 5 times higher heart failure risk, plus increased dementia and mortality. Emergent therapies include refinement in pulsed field ablation, novel atrial selection drugs, AF burden guided anticoagulation, AI tools, and the new AF care framework. Your action plan is simple. Recognize AF early, stage guide prevention, prioritize risk factors modification and early rhythm control, individualize stroke prevention, and consider ablation when appropriate. Schedule your heart rhythm check today. Protect your beat in the 305 and share this with someone you love who needs better heart habit. These notes are designed to flow, and remember always this is only for educational purpose. Thank you so much.